Good evening, and welcome to our third series of ASORN's 2020 IQ webinars. Tonight's topic is Ophthalmic Anesthesia Malpractice Claims by Dr. Ann Menke. The audio and visual portions of this presentation are the sole and exclusive property of the American Society of Ophthalmic Registered Nurses, ASORN, and the presenter. You may not reproduce or rebroadcast any portion of this presentation to any third party without the express written consent of ASORN and the presenter. You also may not give away, sell, or share the content herein. Nursing contact hours are provided by the American Society of Ophthalmic Registered Nurses, ASORN. ASORN is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. ASORN is a provider approved by the California Board of Registered Nurses, CEP number 16717. One nursing contact hour will be awarded after the completion of this webinar. Participants must attend the entire webinar to receive the credits. Credit for a course hour will be denied to individuals who miss more than 10 minutes of that hour. After the webinar, attendees will be redirected to the online evaluation and attendance verification form. All attendees must complete the evaluation and attendance verification in order to receive credits to this webinar. A transcript of your credit will be sent to your provider and email address. ASORN's Planning Committee members and staff have disclosed that they do not have any conflicts of interest related to this activity. And now, tonight's presentation by Dr. Ann Menke. Ann is the Patient Safety Manager at OMIC, the Ophthalmic Mutual Insurance Company, where she has worked since 2004. She analyzes all the medical malpractice claims filed against OMIC policyholders once they are closed. This presentation is based on a study of 10 years of ophthalmic anesthesia claims. And now I'll turn over the time to Ann. And thank you, Ann, for doing this for us tonight.
Thanks so much, Gail. First, I want to take this opportunity to thank all of you nurses out there who are providing care during COVID. It makes me almost want to cry. I'm so grateful. I'm one of many patients who needed care during this, and we know what you're risking to help us, so I did want to thank you. I have no financial disclosures, and as Gail said, I'm OMIC's Patient Safety Manager. So 3 things that I hope you'll understand better after this is that patients can be injured from anesthesia during eye surgery, and I want you to be aware of the 3 top types of injuries so you can watch out for those. In order to prevent these injuries, a preoperative assessment is really important, and I'm going to spend a fair amount of time on that. And then I also want to spend some time looking at office-based surgery. I know prior to COVID, many practices were looking to start doing things like even cataract surgery in the office. So this is something I'm particularly interested in. The first case involves a 66-year-old woman who was referred to a retina specialist for blurry vision secondary to diabetes. He did find diabetic macular edema and vitreous hemorrhage and planned to do a vitrectomy and photocoagulation to treat it. My slides, sorry, are not, the top is cut off, so I'm hoping you can see the top. I can't see the top of my slides for some reason. There we go, that's better. So in this case, the ophthalmologist did the pre-op history and physical himself. In the past medical history, he noted the diabetes, heart disease, and hypertension. He also noted that 8 months prior, the patient had been hospitalized for sepsis from a foot ulcer. Later, it was noted that the ulcer was still present that day. There were no signs of infection, but the ulcer was not discussed during the exam. Her fasting blood sugar and hemoglobin A1C both show that she was indeed a diabetic. You hope to have a A1C less than 7, and that 7 corresponds to the around a 155 blood sugar, and those are showing not excellent control, but pretty good control. In the review of systems, he noted some worrisome things: cough, wheezing, shortness of breath, chills, and an irregular heartbeat, which would have you worried about this patient going to surgery. But in his exam, he noted a regular heartbeat and clear lungs, and also noted that he advised her to stop aspirin. Later, what he testified to was that the symptoms that he noted were when she was in the hospital, not her current review of systems. And even though he did note a history of hypertension, he did not take a blood pressure as part of the pre-op H&P. This ASC had a nurse call the night before, and during that phone call, the team learned for the first time that the patient's heart had stopped twice during that hospitalization 8 months ago for sepsis. They learned that the cardiac arrest had been classified as a PEA, so there was not a pulse. The ophthalmologist did not know about this. Fortunately, sorry, my slides keep moving, I apologize. Fortunately, the anesthesiologist did elicit this history of the PEAs, and like the ophthalmologist, he noticed no congestive heart failure, clear lungs, and irregular rhythm. The glucose was better by this point, but look at that blood pressure, 222/105. That's giving me heartburn right now. So he gave her some sedatives and then fentanyl and propofol and got her ready to go to surgery. Still in the pre-op area, the ophthalmologist performed a retrobulbar block. After the block, the pressure was lower, and she stayed in the pre-op area for 8 minutes and was described as being arousable. And remember, given the medication she was given, the fact that she was pretty drowsy wasn't surprising. When she got in the operating room, however, the anesthesia assistant noticed a pulse of 39 while he was hooking up her lines. He gave her a medication to reduce secretions and called for the anesthesiologist. By the time the anesthesiologist arrived, the patient was in full arrest. During the resuscitation, they were able to get a pulse back and sent the patient to the ER via ambulance. At the hospital, she arrested again, so this was her fourth PEA, was admitted to the ICU, but recovered well and was extubated 2 days later. As in the prior hospitalization, her foot became infected again, and she needed a debridement and a toe amputation. 2 weeks after this, she was discharged from the hospital. They had tried to figure out the cause of the PEAs, but had ruled out everything that they could think of, including sepsis, pulmonary embolism, deep vein thrombosis, myocardial infarction, so they really didn't know what was causing them. After she was discharged, she was weaker, needed to walk with a cane, and she died 4 months later while in a long-term care facility. So when there's a lawsuit, each side hires experts. The patient becomes a plaintiff, and the plaintiff experts opined on the care of both the retina specialist and the anesthesiologist. The retina specialist for the plaintiff said that this patient needed a cardiac clearance. Remember, the ophthalmologist did the pre-op H&P. It wasn't even a primary care physician. So he was really concerned that the ophthalmologist did not send the patient to a cardiologist. The anesthesia expert for the plaintiff immediately said that the arrest was due to the oversedation, not the retrobulbar. This is really important in terms of deciding who might have been responsible. If it's oversedation, it was the anesthesiologist. If it's the retrobulbar, they'd be looking at the ophthalmologist. The anesthesia expert felt that this patient was too sick to have surgery in an ASC, and that's more of the ophthalmologist's decision, but also criticized how the resuscitation was managed, so back to the anesthesiologist. So plenty of blame for everyone. The defense experts, we had retina, cardiology, and anesthesia. We actually had 2 retina experts. The first one didn't feel cardiac clearance was needed, but felt that at least the primary care physician should have examined the patient pre-op, and more importantly, said that that blood pressure should have led to canceling the surgery. The second retina specialist thought that the ASC was an appropriate location and didn't feel there was any need for cardiac clearance, and this opinion was seconded by the cardiologist, who said her problems were due to sepsis, not ongoing health concerns, I would have cleared her for surgery. And our defense expert for anesthesia also felt that the arrest was from oversedation. As you can see, more of the criticism was focused on the anesthesiologist. Excuse me. So he settled for about $1 million. Both the ophthalmologist and the surgery center contributed, and the family got about $1,137,000 in settlement. I just want to point out that obviously the arrests that she had were not the cause of death because she didn't die till several weeks later, but they led to diminished health, and that's why they were able to go forward with the lawsuit and why there were settlements. I want to now go on to a study I did, and I can't tell if your slides are bouncing all over. I hope they're not. I apologize if they are. So I did a study using OMIC data with Dr. Michael Morley, who's a retina specialist who practices with Ophthalmic Consultants of Boston in Boston, and anesthesiologist Karen Nanji. We looked at 10 years of claims from OMIC, and we had the incredible pleasure of having our study published in last month's Ophthalmology. So our conclusions are that ocular anesthesia is safe and that claims are uncommon, and that's really good news because ophthalmic surgery is necessary for so many reasons. In 10 years, only 50 plaintiffs filed lawsuits. They filed 63 claims because they sued more than one person. The case I just presented, the ophthalmologist was sued, the anesthesiologist was sued, and the surgery center was sued. So there are always more claims than plaintiffs. The injuries can be severe, including death or blindness. And it's important to know that some deaths and injuries are not preventable. There are some patient safety experts who say they want to get to zero. There's no way to completely eliminate risk. However, some of the deaths and injuries were preventable, and that's what we wanted to focus on. So in terms of which procedures the patients had, it's not surprising that cataract leads the pack. Now intravitreal injections are the most commonly performed ophthalmic procedure, but usually not a lot of anesthesia for those. So in our study, it was cataract surgery that was the most frequent procedure and retinal procedures, but you can see there's a range of cases that led to problems. Retro or peribulbar were the most frequent type of anesthesia that led to a claim. There was also local, topical, general, and in 2 cases, the anesthesia wasn't general, but we couldn't figure out what it was. So a range of types, but not surprisingly, it's the blocks leading to the most claims. In terms of type of injuries, especially given that the blocks were the most frequent type of anesthesia leading to claims, globe perforations were the most frequent type of injury, but the real surprise for us in our study was death. There were 13 deaths in our study in 10 years, and fully a quarter of the cases, that was the outcome. Also, you can see there were a variety of other injuries, but the 2 biggest ones were globe perforation and death. The blocks were administered, in most cases, by an ophthalmologist. 85% of the blocks were administered by an ophthalmologist, and only 5 by either an anesthesiologist or a CRNA. If the block is seen as the cause of the problem, this means that the focus of the lawsuit would end up being the ophthalmologist in most of those cases. There were 17 cases of globe perforation, and you can see they were all either retro, peri, or some type of block of an uncertain type. And all of the blocks administered by non-ophthalmologists were included in the globe perforations. So still ophthalmologists performing more of the blocks, but all of the non-IMD blocks were leading to globe perforations. The patients who died had, not unexpectedly, a lot of medical comorbidities, diabetes, atherosclerotic cardiovascular disease, congestive heart failure, pulmonary edema, but they all were classified as ASA3. I'm going to spend more time on this later, but the American Society of Anesthesiologists has a classification of 1 to 5. 1 is very healthy, 5 is moribund, not expected to survive the surgery, and 3 is kind of in the middle. And I would say that most patients presenting to ophthalmologists are in the 3 category, especially older patients. Of the patients who died, most had a block, forehead general, but 1 only had topical with sedation. And again, sedation is playing a role in these problems. So what did we learn from our study that we can put into practice to reduce the risk? So I want to talk about what is expected in terms of preoperative assessment. Until the end of last year, the Centers for Medicare and Medicaid Services mandated a history and physical within 30 days, an update to that on the day of surgery, and a pre-anesthesia assessment the day of surgery. In the new regulations published, there are differences. It's the hospital and ASC who has to determine who needs a history and physical. So not every patient might need one. And also they have to determine the time frame for that. It's not an automatic 30 days. And CMS gave some characteristics to look for to determine who needs an H&P, obviously the patient's age, the diagnoses, the number and type of surgeries. I'm going to talk about that more in a minute. Known comorbidities and what type of anesthesia. They didn't provide any details about the pre-surgical assessment the day of surgery, whether that was going to change or not, and there was no comment made about the pre-anesthesia assessment. Well, COVID happened very soon after this, and I'm not aware of any accreditation organizations that have changed their criteria yet, and a lot of ASCs may or may not have changed their criteria yet. So when you think about a preoperative evaluation, it's done because surgery and anesthesia are inherently risky. And we no longer talk about patients being cleared for surgery. Instead, the goal is to identify the level of risk and optimize their condition before surgery if possible. Before the recording started, Gail and I were talking about patients who may have end-stage cancer of some type and still smoke. Some patients aren't willing to modify any of those types of risk factors. There may not be time before surgery to modify any risk factors, but sometimes there is. The other goal of the pre-op evaluation is to anticipate any potential complications and also, as the first case pointed out, decide where the surgery should take place. I looked at some studies on what is the risk of a cardiac event because that's the most common cause of perioperative morbidity and mortality. And apparently, the risk ranges from 1.4 to 3.9% of all surgeries. And in order to reduce the risk and identify patients who are at high risk, the American College of Cardiology and the American Heart Association recommend that you evaluate the procedure type and the patient characteristics. So let's look first at the procedure type. One reassuring thing is that eye procedures are not considered high-risk surgeries. They're not very invasive, there are not a lot of fluid shifts and cardiac stress, and in fact, cataract surgery is given as one of 2 examples of a low-risk procedure. So in identifying risks in patients facing eye surgery, the real thing to look at is the patient. And again, you're not trying to look at all the patient's health problems in a pre-op assessment. You're just trying to decide, is this patient likely to have a major adverse cardiovascular event, which is called MACE. Cardiologists who are looking at this in more invasive surgeries use these risk calculators, and so I looked at them, and I'm going to talk a little bit about one of them called the RCRI calendar. So again, the first characteristic is it a high-risk surgery? We know ophthalmic surgery is not. And then, does the patient have any of these other comorbidities? Ischemic heart disease, heart failure, and I wondered, would a PEA be considered heart failure? Cerebrovascular disease, does the diabetes require insulin, and is the patient in renal failure? So each of these 6 criteria are awarded 1 point and classified. And what you'll notice is that if you have only one of those 6, the likelihood of having a major adverse cardiac event is less than 1%. But once you're up to 2, it's 6.6%, which is actually quite high, and 3 or more, you're up to 11% chance of this. So really, ophthalmologists need to decide, is the risk 1% or less? The cardiologists recommend if that MACE risk is less than 1% and there's no acute coronary syndrome at that time, to proceed to surgery. And this is what the patient in the first case would have been. Now, obviously, no one expects ophthalmologists to look at these calculators, but I just wanted to give you a sense of how you might look at factors that could immediately tell you that a patient might be at high risk. One of the questions we get all the time is, and this first case raised it, who should do the pre-op evaluation? One thing to take away from this calculation of cardiac risk is if the risk for MACE is greater than 1%, then I think it would be extremely prudent to send the patient to the PCP, internist, or cardiologist. If you haven't figured out that MACE risk, any ill patient with significant medical comorbidities needs to be sent to be prudent for a pre-op evaluation. An ophthalmologist who is comfortable and has current competency could do the pre-op H&P if the patient had no high-risk conditions. And if he were to do the H&P, he would want to obtain and document a careful history, a review of current systems, not problems in the past, and any exam elements that history or review of systems prompts him or her to look at. I spoke with a lot of anesthesia providers during the study, and one of them said that he thought ophthalmologists should pay particular attention to patients who could not breathe well when lying down. And examples of patients who would have trouble were patients with COPD, morbid obesity, or sleep apnea. And he said anyone with morbid obesity has sleep apnea, whether it's been diagnosed or not. He also said check for orthostatic hypotension. As you saw in case 1, no blood pressure was taken, much less checking for orthostatic hypotension. But I think that these are really important questions to ask in the history and review of symptoms. And if any of these are present, I would, to be cautious, I think send the patient to the primary care. Let's go on to the second case. This is a patient who presented for possible cosmetic lower eyelid blepharoplasty in both eyes. She had a pretty non-significant medical history. The only condition was anxiety that occasionally needed to be treated with Xanax. And the plan was to proceed with a bilateral lower lid bleph. She wanted to keep the costs low, and so she and the ophthalmologist agreed to do the procedure in the office with local anesthesia. The physician, or the ophthalmologist nonetheless, sent the patient to her primary care for evaluation, and the primary care said that he thought local anesthetic for this patient would be fine. The day of surgery, she signed the consent after removing her contact lenses. Always worry about consent signed on the day of surgery. She took the Xanax, which, remember, had worked for her, and had lidocaine injected. During the surgery, she had excessive bleeding, and that area was cauterized and packed. Right afterwards, in the PACU, the ophthalmologist noted proptosis and globe firmness and suspected a posterior hemorrhage, did a lateral canthotomy and cantholysis right there, and initially the patient improved, and as soon as she was stable, she was taken to the hospital. So both of these cases, the patient ended up being transferred either from the surgery center or the office to the hospital. There, the proptosis increased, so there was a vertical incision performed to drain the blood, and then the patient went for orbital floor decompression surgery. So a pretty big bleed. When she was stable the next day, she was sent to an academic medical center. She was put on hyperbaric oxygen. She ended up having cosmetic reconstruction, but these cosmetic blepharoplasties left her blind in that eye. So again, experts are hired. The plaintiff expert said that a local was contraindicated in a patient with anxiety. Remember, her own physician thought it was okay. He also felt that the blood pressure wasn't monitored properly enough and that Any increased pressure could have increased the risk of bleeding, and strongly criticized the delayed transfer to the hospital when the patient began bleeding. However, the defense expert pointed out that the defendant was an oculofacial plastic surgeon who could do those procedures himself. The plaintiff expert wasn't aware of that. The defense expert also felt that the local was appropriate, especially after having been reviewed by the primary care, and felt that all the procedures needed to address the hemorrhaging were done in a timely manner. The defense attorney gave us a range of what a jury might award from $250,000 to $275,000, but the case actually settled for only $29,000. So what issues came up in this? Saying that patients should have surgery in a hospital might provide you some resources like a code team, but they often don't have the equipment needed for eye surgeries. They may not have staff competent to assist with eye surgeries, and it's extremely difficult to get an insurance company to authorize ophthalmic surgery in a hospital. This patient was on this one wasn't actually on anticoagulants, but patients who are, this is something to really think about before surgery, because they could either have a vision-threatening hemorrhage like this patient, or if the anticoagulants are stopped, they could have a life-threatening CVA or myocardial infarction. So we really think it's important to discuss the plan with the patient and discuss the risks of stopping or not stopping, and that ophthalmologists should not be changing medications they did not prescribe. They should instead contact the prescribing physician before making any changes in that regimen. We have a sample informed consent form that's on our website, and also patients who are on anticoagulants, the anesthesia provider should be told about it. Another issue that comes up is the ophthalmologist's role in choosing the type of anesthesia. Whether it's anesthesia you'll be administering if you're doing a block, or if you're asking for monitored anesthesia care or an anesthesiologist, it's really important to inform the patient of the type of anesthesia you normally use for the procedure they'll have, and explain and document why this is what you usually do. If anything in the patient's history, review of symptoms, or exam indicates higher risk for this type of anesthesia, then you need to discuss these specific risks with the patient. Ophthalmologists have been successfully sued if they choose retro or peribulbar blocks in patients with hemophilia, treatable low platelets, or patients who are deaf or have cognitive impairment and might not be able to communicate well some of the problems, or might not be able to respond well to these type of anesthesia options. They've also been sued if they didn't discuss options as we've recommended. The ophthalmologist and eye care team should communicate with anesthesia, and one easy way to do this is include in the orders a request for the pre-op nurse to inform anesthesia of any abnormal eye structures, any systemic conditions that impact cardiovascular or respiratory risk, and if the patient's on anticoagulants, the plan, either continue, stop, bridge, etc. Who should obtain informed consent for anesthesia care? If the ophthalmologist is performing the block, then he or she should obtain informed consent for the block. But if anesthesia is performing the block or providing sedation or anesthesia, then it's anesthesia who obtains informed consent. The ophthalmologist just discusses as before the options. So whoever is administering the anesthesia obtains consent for it. We're often asked by ophthalmologists if they're liable for care provided by anesthesiologists or CRNAs. They have no direct liability. These are both providers whose scope of practice allows them to provide anesthesia care and without any input from an ophthalmologist. They may have direct liability, however, if the injury is because they did an inadequate pre-op evaluation, or they didn't inform anesthesia of problems that later occurred. There is something called indirect or vicarious liability. If the anesthesia provider is your employee, you do have liability for your employee's actions, or if you're telling the anesthesia provider how to provide the care. And this really means, are you ordering the specific drugs and doses? This may seem like an odd thing to bring up, but what we've learned is that in some states, CRNAs are not allowed to order the drugs they're giving or specify doses. That means the surgeon has to do that. I don't know about you, but I don't know many ophthalmologists who would feel comfortable deciding the drugs and the dosages. But if the state requires them to do that, even if they do it through a workaround, then they could be held liable because they're seen as directing the care. The question also is, what about supervising for CMS purposes? That is not seen as directing the care. If you're asked to sign, if the ophthalmologist is asked to sign anesthesia assessment orders or the anesthesia note, that alone, that signature alone, doesn't prove negligence. They would have to prove that the ophthalmologist did something wrong, such as the things we've talked about, an inadequate pre-op assessment or failing to provide key information. Instead, you can just state anesthesia care provided by Sally Ridley, CRNA. That's just attesting that an anesthesia provider provided the anesthesia care. Let's look for a second at office-based surgery. As nurses, I think we understand better than physicians that the same standard of care applies regardless of where the surgery is performed. Physicians are often really eager to have more control in their own office or their own surgery center and not have to do things they felt were burdensome or unnecessary. But a lot of things that hospitals and ASCs required are to keep the patient safe. So the safety of the patient should guide the decision-making process, not the site. One of the drawbacks of office-based surgery is there's often very little oversight. There may not be a peer review or quality review process. They're typically not subject to the same state and federal licensing requirements. Some states require office-based surgery suites to be licensed, others don't. So there is no one providing input on the care. There's also, in the office there's a less robust rescue capacity. What we know is that sometimes patients go to a deeper level of anesthesia or sedation than planned, and that can lead to a respiratory event or MACE. And at that point, whoever is there needs to have really great skills in airway management and advanced life support measures, and many ophthalmologists and office-based staff do not have this expertise. They've probably had limited experience trying to resuscitate patients who code. There's no code team, and they may not have a full crash cart, or they may not know how to use what's in there. And we actually recommend that, as a general rule, unless you need it for something like surgery, that you have just an emergency kit rather than a full crash cart. So our recommendations for office-based surgery, I apologize for these slides bouncing around, is that they should be limited to patients who are physical status 1 and 2, if there's a risk of serious complications in that. And to go into this in a little more detail, the examples given are from anesthesia experts, they're not mine, but physical status 1 is considered a normal, healthy patient, so this patient is non-smoking and has no or minimal alcohol use. PS2, they might have mild systemic disease, but no significant functional limitations. They're a current smoker, they have diabetes or hypertension, but they're both well controlled, mild lung disease, and not morbidly obese. If the patient is ASA, physical status 3, we think it's safest to do these in an ASC or hospital, not in the office. This is defined as someone who has severe systemic disease with functional limitations, and examples are poorly controlled diabetes or hypertension, COPD, morbid obesity, and those undergoing dialysis. I just don't, think you want to take the risk of performing surgery in your office on someone who's this ill. Our other recommendation is to provide only minimal sedation or analgesia, no anesthesia, you notice. So under minimal sedation or analgesia, you will respond to verbal stimulation. Normally, your airway, breathing, and cardiovascular function should not be impacted at all. You may have impaired coordination or cognitive function, but you still would be able to function quickly. If there are no anesthesia personnel, such as an anesthesiologist or a CRNA, we really don't think it's safe to provide moderate sedation in your office. Hypertension management. Sorry, I don't know what's happening here, but I'm trying to, there we go. Patients with hypertension have increased oxygen demands on their heart. And so we recommend that you consider delaying surgery or ask anesthesia for guidance for any systolic measurement over 160 or any diastolic over 90. You may want to give the patient 5 minutes to relax and retake the pressure for white coat syndrome, but if that second blood pressure is still high, I think consider delaying, especially if it's an elective surgery like cataract, blepharoplasty. If the patient's systolic is greater than 200 or diastolic greater than 110, we think it's really important to cancel surgery and send for treatment. These recommendations were developed in conjunction with anesthesiologists, and again, the priority is to prioritize patient safety. We do have, as I mentioned, the anticoagulant informed consent form on our website, and there's my email if you have any questions for me. And I'm now going to turn it back to Gail to see if any questions came up during the presentation.
Oh, thank you so much, Ann. That was very interesting. I know from my perspective that working in a cancer hospital, we are always on the edge of lawsuits. We get many patients that come that got a wrong diagnosis because their tissue wasn't sent to pathology, or the tissue was sent to pathology and they didn't look at it and it turned out to be cancer. That happens a lot with our DCRs, where they have tearing, they go in to do a DCR and the tissue is actually carcinoma, usually adenoid cystic carcinoma, and we've had 2 instances in my time at MD Anderson where it was the referring physician did not look at the pathology, and unfortunately it was too late, and in both cases we had to take the whole eye. So I'm very aware of this every day, and so what you do is very valuable. If anybody has any questions, we have an expert here, and I was gleaning some information from Ann earlier, and we do have a question. For Ann, it says, do you see any issues come up with failure to adhere to NPO guidelines? How is it handled? Is it often he said, she said?
That's a really good question, and I'm an old nurse, and so how that's managed now, the NPO guidelines now are quite different from when I was a young nurse. I think the most important thing about the guidelines is you follow whatever they are at your surgery center. Those protocols and guidelines you have are all discoverable. What does that mean? That means that the attorney representing the patient has the right to request copies of all of that. And you may have done everything else right, or what you did wrong didn't really cause any harm, but if you violated your own policies and procedures, as they say, that can and will be used against you in a court of law. So I think the thing is to really know what they are. We did have one case where a patient lied about when he had last eaten. They were planning general anesthesia. I don't think this was in this study, but in a prior study, and he just lied. Well, he vomited, aspirated the contents, and ended up, dying from it. And, if someone's not going to tell you the truth, then there's nothing you can do about it. So the family sued, but that lawsuit was dropped. But that's another one where you want to make sure that the ophthalmologist knows what the recommendations are, that everybody's on the same page, and that whatever is decided in your surgery center on whether liquids are allowed or nothing after a certain point. So then what if you find out that a patient tells the truth and says, gee, I did eat? What do you do? Believe it or not, we've had lawsuits where nobody does anything. That's the wrong approach. You have to go tell the surgeon and the anesthesiologist and act as a patient advocate. If someone who's going to have general anesthesia ate recently and they don't seem concerned as a registered nurse, I think you need to push it a little bit. So you definitely need to notify both the surgeon and anesthesia. It's the same issue comes up with anticoagulants, interestingly enough, if they were told to stop. We had a case where a patient was told to stop the aspirin and was asked about it and said no, she hadn't. Nobody said anything, and she had a severe hemorrhage and suffered severe consequences. So the nurse actually did, I take that back, did say something to the surgeon who decided to proceed anyway. Those are hard calls as nurses. If you disagree with the surgeon, you really want to do your best to keep it a team approach and to articulate why you think this isn't safe for the patient. And document as neutrally as you can. Your notes will be on a screen in a lawsuit, so you want to be very neutral about exactly what you told the surgeon or anesthesiologist and what their response was. So thank you for that question.
Yes, that was a great question. I have another question for you, Anne. It says, first, great talk, and yes, it was. Does OMIC have any published guidelines for blood pressure, blood sugars, et cetera, for their members? This would be helpful for the offices.
We do. The blood pressure, the hypertension guidelines that are in the slides are part of our office-based surgery recommendations. We're in the middle of doing a big study on office-based surgery. Those may or may not change, but my email, I believe, might still be up. Feel free to email me and ask me to send that to you, and you'll see the recommendations. Maybe I can go back. Oh, there it is. So here are our recommendations. Consider delaying surgery or ask anesthesia for guidance for systolic above 160 or diastolic above 90. Cancel surgery and send for treatment for systolic greater than 200 or diastolic greater than 110. So those are our office-based surgery recommendations.
Oh, great. I know that helps a lot. I'm trying to figure out a blood sugar question from one of our...
blood sugar. Thank you for that question.
Yeah.
We don't have recommendations on that, and I have to say it's never been an issue in an ophthalmology lawsuit. Obviously, if the patient's diabetes is very poorly controlled, it might impact any postoperative infection. More a worry, especially in offices, is hypoglycemia. So, I would know what the normal range is and ask questions for anybody who's outside of that normal range and have something you can give patients who are hypoglycemic. But I don't remember this being an issue in ophthalmology lawsuits.
So I have another question, and this is very pertinent to today. Do you anticipate claims regarding COVID-19 safety?
Yes, sadly. It breaks my heart. We're already getting physicians who are being threatened with lawsuits. When they were told not to do surgery and followed those guidelines and sometimes regulations, patients were upset and have already said they're going to sue. When patients are being asked, again, according to CDC guidance and common sense, to wear a mask, they're being threatened with lawsuits. On the positive side, federal and state governments are looking to pass laws providing what's known as immunity for physicians and healthcare providers for this period. Why? Because so much was completely out of your control. You had to follow state laws. You are expected to follow CDC guidance. And so what we tell our policyholders is, at a minimum, follow requirements and take into account CDC guidance, the guidance from the American Academy of Ophthalmology. They did such a great job very soon after the Don't Do Elective Surgery. Each subspecialty came up with a list of what was considered emergent, urgent, and elective. And what I called a physician back who was being sued for not doing elective surgery, and I said, if this patient sues you, all we have to do is produce this list. not only were you following the law in your state, but this was consensus guidelines from your specialty, and obviously you were doing the right thing. One law firm in Texas who only represents patients, so Plaintiff, came out with an announcement maybe a month or so ago saying that they refuse to take any COVID lawsuits. They said, we cannot, in good conscience, sue physicians, nurses, and other providers who are putting their own lives on the line to provide care during this and then question their judgment. And they also pointed out that they have very little control over it. So, you know, unfortunately, litigation is our national pastime. It's one of our favorite sports. We do expect lawsuits, but we think that for the most part, juries will have no sympathy for frivolous lawsuits. And if you had no control, I don't see how you should or could be held liable. So it's a big worry for physicians right now. So thank you for that question.
It is a big worry. We had to put off a lot of cancer patients during COVID, and we went up starting in May to start surgical services again. And if your COVID test is positive, I tell patients your surgery will be canceled. There's very few surgeries that we really do if you're COVID positive. We do have a COVID positive room if it's a life-threatening surgery, but if it's something that can be put off, we do put it off. And most patients are pretty gracious, I have to say, and I know they're very concerned, and I worry for them myself. But
well, we know there have been some studies that the damage to patients' health and well-being from these delays in care is real. It's called collateral harm, that the lack of access to care, the delays in care are having significant impacts on patients, long-standing impacts. We know patients have died because of it out of fear of going to the emergency room. Many patients will have impacts that can't be reversed once care is available. And also, I hear from our policyholders, trying to get everybody back in, you can't. You're working 7 days a week, and you can only see so many at a time. It's just a horrible situation for all of you, and that's why I started by thanking you for providing care during these circumstances. So, again, our advice is follow local and state health department mandates, be aware of CDC guidance, of American Academy of Ophthalmology guidance, and use your best judgment, and that's all you can do. And all of the professional liability carriers are going to stand behind everybody on this. We just all feel very strongly about it.
Well, thank you. I will leave with a little lightheartedness. I did have a patient tell me today he was going to sue me because I changed his MRI of the orbits to a CT of the orbits because he had a pacemaker, and he just didn't want to have a CT. And I said, well, if you'd like to do that, you can, but I don't want your pacemaker to fail, because at MD Anderson, we rarely will do a MRI with a pacemaker because we've run into problems, and especially patients that are a little bit shaky with their pacemakers, we just don't put them in an MRI. So I do run into that occasionally, but I just smile.
Yeah, I think what we need to remember is that everybody is rattled by everything going on right now. 30 million unemployed. There's just so much stress out there, and it's usually not bringing out the best in any of us. And so I think the most important thing is to practice kindness as much as you can, because we're all suffering and struggling under this. So, and don't lose your sense of humor.
I think that's true, and I think this was a really timely talk. So if there's any more questions, we do have time for that. Otherwise,
I wanted to go back, if there isn't one, to what you started with about delay in diagnosis in cancer patients.
Yes.
I didn't put up the slides of what a plaintiff has to prove in order to win a malpractice case, but one of them is causation, that what you did or didn't do was the cause of the outcome. In a lot of cancer cases, depending on how aggressive the cancer is, it may not have made any difference. If it's a condition for which there is no effective treatment, or you were already so advanced by the time you got to the physician you're suing, if your vision was already pretty much lost, that's called a causation defense. Maybe the care wasn't what it should have been, but it didn't make any difference. And so it's not like anything any person likes to hear. And I've had personal experience of this because my sister, none of her providers checked her pathology report after her mastectomies for 8 months, despite her saying she wasn't doing well. And when they finally checked, it had metastasized everywhere. So it's really important to follow up on those test results. But sometimes even if there is a delay, it may not have made a difference in the outcome. And so it's a weird perspective on that, but in the malpractice world, that's important.
Well, that is a different take on it, because I never know how it ends with these patients, and I don't really like to pry into it because that's something we just really don't want to harbor on. We just want to make sure they don't get metastatic disease as the next step. So, but that is interesting. So I appreciate that. And if there's any other questions, we have Anne's expertise, and it comes at a very timely. All right. Well, then the successful completion of this webinar, an email you will receive to log in to this webinar contains the link that you must use to take the online evaluation and attendance verification form. If you do not have this email, please contact ASORN at asorn@aao.org. All attendees must complete the evaluation and attendance verification in order to receive credits for the webinar. A transcript of credits will be sent to you to the provided email address. And again, I'd like to thank you for attending, and most of all, I'd like to thank Anne for her expertise.
That was my pleasure. Thanks to all of you who have given up some of that precious free time. I hope something in this was useful.
It was very useful. Thank you so much. Good night.